Hello, I'm Dr. Jonny Martell, an NHS psychiatrist. I'm first and foremost a clinician, not a drug policy wonk or academic. So I'm coming at this issue from the coalface, so to speak. I was one of two study doctors working on a recently completed study comparing a conventional antidepressant drug, escitalopram, with psilocybin-assisted psychotherapy. This was for people suffering with depression and took place at Imperial College London. The study was primarily looking at how these different treatments work in the brain, but also, of course, we're very interested in how they fared head to head. The results were very encouraging. Psilocybin-assisted psychotherapy improved participants' depression symptoms more than the antidepressants and brought about remission in 28% more of participants in the arm receiving the psilocybin-assisted psychotherapy. And also, very importantly, the psilocybin therapy arm had a much more favorable side effect profile. Depression is such a varied condition. There will be no one magic bullet cure for it, but alternatives to current treatments are desperately needed. Already, it's the single largest cause of global disability and the largest contributor to suicide. Every day in the UK, on average, 16 people die by suicide. Or for those more moved by money, depression costs the economy £10 billion annually. So as I said, alternative effective treatments are desperately needed. Up to 30% of people don't respond to antidepressants. Many patients find the side effects intolerable. And CBT, or cognitive behavioral therapy, for which the waiting lists are long, simply doesn't work for a sizable majority of sufferers with complex personal and social histories. The current scheduling of psilocybin is not just an absurd byproduct of cultural and political forces, it's literally costing lives. I've seen the limitations of our current treatments on a daily basis, and this not just in patients I see, but in my own family. 2 generations have died by suicide, both my father and his mother. So I feel compelled to get behind this campaign to reschedule this compound. Schedule 1 regulations make it substantially more difficult, costly, and time-consuming to conduct this vital research. These barriers mean that fewer studies happen, valuable new medical therapies are slower to bring to market, clinical trials are smaller and recruit fewer participants, and many studies simply don't happen at all. Psilocybin could be moved from Schedule 1 to Schedule 2 with special statutory limits, restricting access to scientific and medical studies, thus avoiding the very small risks of inappropriate prescribing and diversion. The impending recession that will deepen the country's current mental health crisis only adds to the clear moral imperative for the government to act on this evidence-based call for rescheduling. Part of my role in the trial at Imperial College London was choosing who was suitable for this treatment. And we had to think a lot about this. Like with any medical treatment, some people aren't suitable. It requires quite a lot of trust, the process. Participants in the trial or patients receiving this therapy are asked to confront a lot, sometimes of their own past, sometimes of aspects of themselves that they've lost familiarity with. In some cases, there is significant trauma history, so it's very important that we recruited participants that could trust in us to care for them, and could trust in the process. So that was something we were looking at a lot. We were also looking for a pretty strong degree of psychological mindedness, so a curiosity in participants to think about their suffering, their depression. So I suppose our focus was a little bit removed from, I guess, the dominant biomedical paradigm that informs a lot of research into depression, seeing it just as a disease of the brain. We were looking for participants who we're certainly open to thinking about depression being not just a problem in the brain, but maybe a crisis of meaning, or a product of their story. So yeah, that was some of the work we were doing, and we screened many hundreds of people. There was huge interest in the trial, and yeah, we thinned that interest out with telephone calls and face-to-face screening. But we're certainly very mindful of participants' medical history, psychiatric history. So we were looking for people without a history of psychosis, for example. That's always a pretty strong contraindication in this work. And yeah, they were. We wanted to be sure that they were mentally and physically robust enough. This trial was specifically looking at the treatment of people suffering from depression. There's a number of other trials going on in the UK and globally into treatment-resistant depression, so it's a small distinction. In our trial, we were requiring people who were suffering from depression, not people who had failed a particular number of treatments. Aside from psilocybin, and there have been trials looking at psilocybin to treat OCD with very encouraging results. Also various end-of-life difficulties like anxiety, depression. So there have been studies in the US looking at how psilocybin might treat anxiety and depression in end-of-life settings, again with very encouraging results. But aside from psilocybin, I suppose the other big compound which is being explored throughout the world, and I think there are some studies starting up in the UK, if they're not already happening already, is MDMA, which is proving very effective in treating PTSD. My understanding is that the Food and Drug Administration in the US are quite close to approving this treatment. As things stand, I think it's pretty shameful that many veterans in the UK are travelling abroad to find effective treatment for their PTSD. In Holland, there are many treatment centres offering offering various treatments with psychedelics for PTSD. Many are travelling to South America to seek out this treatment. The research in the UK is mostly coming out of Imperial College London and King's College London. These are really very well-established research centres looking at both the pathology itself of different mental health disorders and their treatments. Imperial College London has got what now can only be described as a very strong pedigree looking into psychedelic compounds, their effects on the brain. It's a well-established team led by Professor David Nutt and Dr. Robin Carhart-Harris, who together both of them have been using various different brain imaging modalities to look at how these different compounds affect the brain. So they're a very experienced team working safely, doing cutting-edge neuroscientific neuroimaging research into these compounds. And over recent years, they've pulled in a very good clinical team around them to look more at the clinical what can happen clinically with these compounds to treat various psychiatric conditions. King's College London is probably historically and still now the biggest psychiatric neuroscientific research centre in London, in the UK. And there's a psychiatrist called Dr. James Rucker, who has got a lot of experience through Imperial and is now running various studies out of there. Going forwards with rescheduling, it would offer an enormous boost to the life sciences industry in the UK. Alongside these two main centres, there are also trials going on in Newcastle, in Manchester, and also in Bristol, and I think in Cardiff as well. These new centres, I suppose, are relatively young compared to Imperial and King's, but there is obviously an enormous need and appetite for more of this research. With rescheduling, these kinds of centres, they have the infrastructure, they have the personnel ready to take this forward, and this needs to happen to treat this enormous unmet need. And yeah, it's just it's a question of this rescheduling happening. I've gone back to clinical practice since this study's happened at Imperial College London, and it's an enormous source of frustration working with the really quite limited tools we have to treat depression, especially. We, as a profession, haven't produced any new treatments really in a very long time. The same molecules, these antidepressant drugs called selective serotonin reuptake inhibitors, we've tweaked them over the years. There has been no new treatment. There has been no new way forward to treat depression in a very long time. There are a number of psychological therapies, and these can be very helpful. They can be costly. But again, there's been nothing new to the table in a very long time. This, in my view, is an enormous paradigm shift working with psychedelics. For many people receiving antidepressant treatment and even the conventional psychological therapies, there is an experience for many patients of them being quite palliative, so dampening down symptoms, but at the same time also dampening down feelings across the board, especially with antidepressants. Many describe them as being more palliative in nature, as opposed to being a more transformative treatment that can look at the root cause of people's depression and their suffering. So yeah, it's been, in some respects, it's been a bit of a struggle returning to clinical practice, knowing that these treatments are out there. We do need more data, we do need more research to ensure that they are as effective as all the early studies are pointing towards. But that shouldn't take the amount of time it will take as things stand with this current scheduling. It's something that should be able to be licensed in a much, much shorter period of time. And yeah, it's heartbreaking to see people who have been suffering from depression for many, many years, have tried countless antidepressant drugs, are seeing their GPs or psychiatrists, and they've kind of reached the end of the road. We need new treatments. It's as simple as that. So the current scheduling of psilocybin is, in my view, it's costing people's lives. It's costing lives. We know from data spanning many, many years that depression is a leading cause of suicide, of disability, and there are enormous economic repercussions for undertreated, poorly treated depression. The existing scheduling is, it's a product of politics, of social history. We know from huge surveys that psilocybin is a safe compound. It has absolutely no potential for addiction, unlike other substances such as alcohol, which are legal and it's an encouraged industry. Psilocybin is entirely safe, especially when used in a medical setting. The frameworks for this medical setting, they are really very well refined. through the research that's happened. It's costing lives because the current schedule is so incredibly prohibitive, cost-wise, bureaucratically. There are teams across the UK and around the world that are well developed. We have the protocols, we have the infrastructure, and we have the desire to get these treatments to market. The rescheduling, it has to happen. It's an ethical, moral duty of people involved in government to ensure that this happens.